So it's my pleasure to introduce Dr. Raquel Walsh Jahnke. It's a mouthful. She's a Minnesota native. Completed her Bachelor's of Science here at the University of Minnesota in the Twin Cities, and it was in genetic cell biology and development. She then moved to Kansas City, Missouri, and received her doctorate in osteopathic medicine from the Kansas City University Osteopathic School of Medicine. And she followed that with a residency in anatomic and clinical pathology at the University of Kansas Medical Center. We were very fortunate to have her as a transfusion medicine fellow last year. She completed her fellowship in June and then immediately went into the Hematopathology Fellowship where she is currently working. She's already has her plans lined up for next year. She'll be in private practice in Wilmer, right? Which is near her hometown. And so she'll start there next summer. When she was with us, she worked on a number of projects, a couple of them with Dr. Claudia Cohn. One of those she'll be talking about today. She also worked with Jed Gorlin on a prevalence of blood donor iron deficiency and feasibility of ferritin-based iron replacement. And she's currently working on a project with Dr. Michael Linden and myself on relapse rates in patients receiving plerixafor for stem cell mobilization for autotransplant in myeloma. So today, she's going to talk on one of her projects which involved red cell alloimmunization in cord blood. And this is one of the projects that Dr. Cohn mentored her on. And with that, I'll turn it over to Raquel. Do I turn that off?
I think she said it goes off.
Does it automatically? And that's okay.
Okay. Thank you, Dr. McKenna, for that very nice introduction. As Dr. McKenna stated, I am a native of Minnesota. I grew up here, was born and raised. I did my undergraduate at the university here in Minneapolis, so I kind of bleed maroon and gold. I did leave for 8 years to go to Kansas City, but eventually wanted to come back and complete my training here with my interest in transfusion medicine and hempath as the programs here were so good. But also part of that interest stemmed from the rich history that Minnesota has in the bone marrow transplant world. So part of my talk is going to just go over some of the history of bone marrow transplant at the University of Minnesota. I do realize there might be some people in the audience who know more about this history than me and possibly lived through it. But part of it is to share it with some of the people in the room who maybe don't know this history as well. So here we go. And I thought it was very fitting on my walk in this morning. The sky was also bleeding maroon and gold. So I took a picture of my iPhone and thought I would share it with you. Everyone was taking pictures of it. It was very pretty. So I have no disclosures. So the objectives of my talk, we're going to discuss the history of bone marrow transplant at the University of Minnesota, how umbilical cord blood transplants came to the forefront and how the university played a role in that coming about. And then we're going to go into a project I was brought on with Dr. Claudia Cohn regarding the development of red cell alloantibodies in umbilical cord blood transplants. So the history of bone marrow transplant, the studies with it go back to the 1920s. There was a Danish researcher by the name of Dr. Fabricius Moller, and he was looking at guinea pigs. At the time, there was concern about irradiation effects on people, so they were studying it he was studying it in guinea pigs, and he showed that if you shielded the guinea pig's hind legs, they were protected from the bleeding diaphyses that were seen with the irradiation. However, his research was interesting but didn't really get a lot of attention. However, as we know, post-World War II, the United States, this is the bomb at Hiroshima and this is Nagasaki, which were nuclear bombs that were put on Japan and caused a lot of irradiation effects to the people there. So it really re-energized this research on what radiation does to people and ways to possibly treat and prevent the effects of it. So this is one of the first studies that was published post-World War II. This has been something I'm proud of. It was the Journal of Laboratory and Clinical Medicine in 1949. So this was Dr. Jacobson, and he kind of took Dr. Fabricius Moller's studies and tried to repeat them. So he took mice and irradiated them, and they died of effects of radiation. If you showed if you shield their hind limbs, they were protected from these damaging effects. But he took this research one step further, which was quite interesting. So he took the mice, he irradiated them, but instead of shielding their hind legs, he injected their own spleen cells back into the peritoneum and found that they could, too, be protected from the effects of the irradiation. So showing that there was something being lost that you could reinfuse after the effect and get protection. Ford et al. In 1956, this was published in Nature, was the first to describe what we know, what was called at the time as a radiation chimera. So he wanted to prove that you could possibly take cells from something non-self and then put it into the mice. So they took mice with a normal chromosome subset, and then they irradiated them, and then they injected spleen cells from mice that had either translocations or small marker chromosomes that they could detect by G-banding studies. We didn't have PCR back then, so this is what they did. And then after injecting these spleen cells, they did engraftment studies. And these are the pictures from that paper, and you can see that they proved that here are the marker chromosomes and translocations, that you could take cells from another animal and transplant it, and it could engraft successfully. In 1957, Barnes et al. In the British Journal of Hematology was the first to describe what we now know as graft versus host disease. So they took mice with leukemia, irradiated them, and they gave them cells back, and saw that they would die of their leukemic disease. And then they also took mice, irradiated them, and gave them homologous, was what they called it in the paper, which is allogeneic spleen cells, injected them, and noticed that they were living without disease. However, 100 days, weeks to months after this transplant, they described that the mice were dying of severe diarrhea. And they didn't exactly know what was going on at the time, but we now know this was the first published manifestation of what we now know as graft versus host disease. This is just a general timeline of how bone marrow transplant came to the forefront in humans. The first successful bone marrow transplant in a human was done in 1956 by a doctor of the name Dr. Donald Thomas in Cooperstown, New York, and he showed that he successfully cured a patient of leukemia by irradiating that person and then giving her identical twin sister's bone marrow, infusing it later. So I was able to cure her. However, most of us don't have identical twins that we can transplant with. Dr. Williams, I don't know if she's here. She's maybe one in the room who would. I'm a twin myself, and it still is not enough to have a matched transplant. So really, that transplant didn't take off because most people didn't have a clone of themselves, essentially. It wasn't until 1958 where a critical discovery regarding the immune system was made. This is a French researcher by the name of Jean Daussé. Claudia probably will pronounce it better than me with her French. But he discovered what he called the human histocompatibility complex on chromosome 6. And what he found were these antigens were present and were very specific to a person, so they could identify something as self. And then if something foreign came in, they could fight it off and get rid of it. So he proposed that this was part of the reason why a transplant of non-identical cells was not allowing or they weren't surviving because of the graft versus host disease. So the HLA complex is very interesting. It's inherited as a haplotype because these genes are so tightly linked on chromosome 6. So, for instance, the A1BADR17 is one of the most common haplotypes in the Caucasian population. And so a father will pass on one of his haplotypes and a mother will pass on one of her haplotypes. So you have 4 different combinations of haplotypes that can be passed on to your children. This discovery led the way to realizing that 25% of people with the same parents will have the same HLA type. So it kind of opened the world to transplanting using siblings as donors. There are occurrences where you can get crossover of these HLA antigens, but that's an uncommon occurrence. So 1968 proved a seminal year in this story. This is Dr. Robert Good, who was at the University of Minnesota at the time. So he was treating patients with immune deficiency, and they were good patients to possibly do a trial of these transplants because it was thought that they did not have the immune response to get the graft versus host disease. So a letter arrived to Dr. Robert Good from a doctor in Connecticut describing a 4-month-old male infant who had 4 older sisters. And so that little boy and his family came to the University of Minnesota in July of 1968 to see Dr. Robert Good. This is the pedigree of that child. You can see in the blue square that is him, and he had 4 older siblings. And he had a long-term family history of early male infant deaths due to infections. So it was following a pattern of X-linked severe combined immune deficiency. So even though we knew that 25% of siblings should be an HLA match, there wasn't sophisticated HLA typing that we could do at the time. So what they did is they took his cells and did a mixed lymphocyte culture with his 4 sisters and picked the one that had the least amount of reactivity. And I believe it was actually his oldest sister that ended up having the least amount of reactivity and was assumed to be an HLA match. One thing they were worried about was they were not ABO matched. He was type O and she was type A. So they were a little bit concerned what that would do. But they took 55 cc's of bone marrow from his sister, injected it intraperitoneally, and didn't really notice much happen, so they had to go back again and collected a second time, and this time they started noticing that he started engrafting with cells. And one of the most exciting things that Dr. Robert Good says in his paper, there's 2 kind of exciting things. One was his blood type changed from O to A. So that was one way they could prove that his cells were no longer his, but his sister's. And then also, he was exposed to chickenpox in his post-BMT course, but he never contracted the illness. So they were saying that not only did his blood type change, but possibly her immunity to that, because she had been exposed, conferred immunity to him through the transplant. So this boy, to my knowledge, is still living today. He's almost 50 years old. I read one article that he's embarrassed to give interviews because he doesn't even remember anything about this event in his life. So you won't find pictures of him, but we do know that he is alive and well and cured of his disease. So one thing to note, this is a picture of Minneapolis in 1968. It looks pretty similar, I would say. Maybe besides, you can't see it in this picture, but the ship, like my son calls it over here. And there's probably a lot less traffic, I would say. And my husband actually went out just a few nights ago and he took this picture. I said, that's perfect. That's the exact same picture from 1968. So this is Minneapolis today, again, with a lot more traffic. But our experience in transplanting patients with immune deficiency kind of allowed us to get a lead in terms of bone marrow transplant, and also we were the first, along with the University of Washington in Seattle, to describe a clinical grading system for graft versus host disease. So it's just very exciting that the University of Minnesota was the first place to transplant a person, a matched sibling donor. The University of Minnesota made headlines again. There was a boy by the name of Dave Stahl in 1975. He was 16 years old and he had disseminated Burkitt lymphoma. He was given 6 months to live, so they decided they were going to try to attempt a bone marrow transplant to cure him of his illness. And he had a matched brother. His older brother was an HLA match for him. So they transplanted him, and he had a very mild post-BMT course. And as you can see, that's Dave Stahl in 2009. So he is, again, alive and well and cured of his illness through bone marrow transplant. So he's the longest living survivor of bone marrow transplant for lymphoma. Burkitt lymphoma, we would not go to an allogeneic transplant right off the bat anymore, but at the time, that was the best thing we had. The story, this girl, little Laura Graves, she was a young girl who was diagnosed with acute lymphoblastic leukemia. She was not at the University of Minnesota, but you'll see how it relates in a moment. But she did not have any siblings as a match for her. So her family went to actually the HLA typing of the platelet donors in Colorado at the time to attempt to find a donor. At this point, there had been no unrelated bone marrow transplants performed. And oddly enough, they did find her a full HLA match using typed platelet donors. But what's even more interesting, Dr. McCullough told me this. Her donor, her donor was one of the lab techs on the bench in that HLA lab. So it's just quite fascinating to me. She was transplanted and went into remission for several years. Unfortunately, I think 3 years post-transplant, she had relapsed leukemia and then she did pass away. But her family, after her death, started going to cities. This is Milwaukee, Seattle. I couldn't find a picture of St. Paul and Iowa City, but those are kind of the big ones they were going to. And they started these HLA drives to get patients who did not have matched sibling donors, to give them an unrelated donor. However, they realized that just going to cities to get HLA typing was not going to be sufficient for most people. So they realized that a national HLA registry was going to be required. So a bunch of physicians, patients, including Laura Graves' family, went to Congress to try to pass a National Marrow Organ Donor Act. And there were several key players who went to Congress. This was in 1984. And one of the people that you will consistently see that was there was our own Dr. Jeffrey McCullough. He never told me this. I read it, and then I had to ask him about it. And then he was happy to share it. It was very exciting to me. So the National Marrow Donor Act got passed in 1984, and then the National Marrow Donor Program came to fruition. And it still is what it is today. It had several name changes. It started at the Red Cross in St. Paul, and then moved to 36 or 35 and 280, but now it is downtown Minneapolis. So again, another Minneapolis connection. So the National Marrow Donor Program looks to get patients unrelated bone marrow transplants if they don't have matched siblings. So it would make sense. 30% of people have a matched sibling donor if they require a transplant. Most people have 2 or 3 siblings, so that kind of makes sense. The lucky people who have 8 or 9 definitely probably have an HLA matched sibling. But even with the NMDP, you only get another 12% of patients to get a donor. So that left half the patients still without a matched donor. So other efforts started to be made to look for other sources of transplant. So 2 of the main ones that come to mind are cord blood transplant and haploidentical or half match, so a sibling that's half matched or a child that's half matched. I'm not going to discuss in detail, but the haplo-matched transplants have really started to become a thing in the recent years. But cord blood is also a viable option. It was thought that it was rich in stem cells and obviously was babies born all the time. You can collect it from the placenta. So it's thought to be a good, viable option. So this is the last history I'm going to say about the University of Minnesota, but Dr. John Wagner was the first, the first umbilical cord transplant for a malignant condition was performed here at the University of Minnesota. There was a child prior to this who was transplanted with Fanconi anemia in France prior to this. But this patient had, it wasn't called it at the time, but what we now know is juvenile myelomonocytic leukemia, or JMML, and also neurofibromatosis 1. Had two older siblings that were not HLA matches, but his mother was 36 weeks pregnant at the time. And so they delivered his sibling, and they collected the cord blood, and from experience from that prior case, they knew that you could freeze the umbilical cord blood and transplant it at a later date. So that's what they did. They froze, did the testing on the blood, and they found that that baby was a full HLA match for this child. So they transplanted the umbilical cord blood, and this child went into remission following transplant. I didn't get long-term follow-up, but at the conclusion of the paper, the patient was still doing well and in remission. So umbilical cord blood is an interesting source for stem cells in the fact that babies are born every day. It has very little to no risk to the donor. And also it was thought that the naivety of the T cell component in these umbilical cord bloods would allow or would lead to less graft versus host disease, which has come to be true. This is just a couple slides of showing how many transplants we've performed at the University of Minnesota. In 2014, we did about 275, but overall have done about 7,000 total over our whole history. The distribution of transplants, we do a lot of cord blood, autologous for multiple myeloma, non-Hodgkin lymphoma, Hodgkin lymphoma type of things. And then as you see, the bone marrow and unrelated still is a small piece of the pie. This is just showing the types of conditions that are transplanted in the pediatric service. Metabolic, you have solid tumors and then also hematolymphoid neoplasms. And here's that wedge that made us famous, immune deficiency. So we still do transplants for immune deficiency, but it's a much smaller piece of the pie. In comparison to the adults, most of the transplants are for some type of neoplastic condition. So there's a little difference in the reason for transplant between adults and pediatrics, which is true all over, not just here. So now I'm going to go into the project that I was brought on by Dr. Claudia Cohn. So as we know, hematopoietic stem cell transplant is used for a multitude of different conditions. So the preparative regimens to allow the patients, and we're going to go over a little bit what that is, but the preparative regimens to get patients ready for transplant lead to marrow ablation and pancytopenia, which require transfusion support until engraftment occurs. So umbilical cord, we kind of said the benefits of it. You get decreased acute graft versus host disease, and also it's a source that can be stored for long periods and gotten from people who don't otherwise have a transplant. However, umbilical cord blood transplant is also associated with delayed engraftment due to decreased CD34 stem cell counts in it compared to peripheral blood or bone marrow. And then also poor immune reconstitution, probably leading to higher rates of infection. And then also because of the delayed engraftment, require more red blood cell transfusions post-transplant to get them to the engraftment phase. So despite significant immune suppression, there have been several studies showing that patients post-transplant still have the ability to elicit immune responses to red cell antigens that are foreign and produce alloantibodies. This is most studied in sickle cell patients. Around, up to 10% of them can develop red cell alloantibodies, but it's thought to be about 2%, 2 to 8% in the stem cell transplant world. So the hypothesis of this study, the original motivator to doing this, was thinking that patients undergoing a cord blood transplant receive more red cell transfusions. And so we were looking at whether they made more red cell alloantibodies because of those increased number of exposures to foreign antigens. Before I go into what we found in our study, just a quick overview of the preparative regimens. In some of those first studies, they did just total body irradiation, and as you can see, that's the lowest intensity type of regimen you can do. So as you increase intensity, you get more ablation of the marrow. So especially in a patient with a malignant condition, you want to completely wipe out their bone marrow. But there's a large spectrum of preparative regimens that can be used. However, as you increase your intensity of regimen, you also increase toxicity. So there's a lot of patients, depending on their diagnoses, their comorbid conditions, and especially their age, who cannot tolerate these high toxic, high intensity type of regimens and will undergo more reduced intensity type of preparative regimens in the hope that it will be counteracted by a graft versus tumor effect. So what we did, there were 943 patients who underwent bone marrow transplant over a 4-year period. These included autologous transplant, allogeneic, the whole gamut, cord blood, peripheral blood apheresis, bone marrow, and also within each category there were patients who underwent myeloablative and non-myeloablative or reduced intensity regimens. We collected demographics, diagnoses, stem cell date and type, if they developed red blood cell alloantibodies or not, and then how many red blood cells were transfused. So of the 943 patients, 2.2 had possession of red blood cell alloantibodies prior to transplant, and 1.6% developed antibodies in the post-transplant period. So we wanted to just see if patients have antibodies prior to transplant, what happens to them? Do they stick around? Do they go away? What happens? So we looked at these 2 patients who underwent autologous transplant, had persistent antibodies, which would make sense because you're essentially transplanting your own cells back. 30% lost the red blood cell antibodies prior to transplant. 50% lost them in the post-transplant period, and another 10% had persistent red blood cell antibodies. However, something of interest, these 2 patients who had persistent antibodies post-transplant both underwent reduced intensity regimens. So which would make sense if you're reducing the intensity of preparation, you're going to leave some cells behind. So it would make sense that you're allowing these people to have persistence of their production of the antibodies by their plasma cells. The overall prevalence, cord blood patients, 2.2% developed antibodies post-transplant, 1.4 in the peripheral blood and bone marrow group, and 0.4 in the autologous transplant group. So again, the 15 patients with red blood cell antibodies post-transplant, one went under autologous transplant, so we excluded it. And the reason we were excluding these is it just confused the data to keep autologous in our numbers, so we excluded them. So of the 15, 10 of these patients underwent umbilical cord blood transplant. And one thing to note is that 8 of these 10 people had development of warm autoantibodies. So these are either pan-reactive or reactive against the patient's own red cells. So this was a finding that was kind of unexpected. We weren't sure what to make of this, and then also they made cold autoantibodies as well. And then only 4 patients in the peripheral blood bone marrow, and of note, none of these patients had a warm or cold autoantibody. So we're going to be getting to this a little bit later. So we compared, excuse me, we took the patients who developed antibodies and we looked at the number of transfusions they received. And overall, there was not statistical significance, but it looks like there was a trend towards umbilical cord blood transplant patients, at least in the ones who developed antibodies, actually received less transfusions. We did not look at the number of transfusions of patients who did not develop alloantibodies, but that might have changed. Claudia says they did. So we wanted to see in the myeloablative versus reduced intensity, did these patients develop more alloantibodies than the other? And again, they developed the same amount of antibodies if they developed them. So no statistical significance. We tried to divide the data even further to try to see if maybe are these alloantibodies, does it have a relation to the number of transfusions they receive? And again, there was no statistical significant difference between the two. However, when you look at it and separate it out for adults, again, it didn't reach statistical significance, but it seems that cord blood transplant patients developed more alloantibodies compared to how many transfusions they received. But the opposite was true in pediatrics. So we weren't really quite sure what to make of this, so we decided to start looking at the data in a little bit different way, and it's kind of bringing us back to the preparative regimens that were used. So 15 patients again, we excluded the one autologous, and then we separated the pediatric and adults, and we can see that really actually there was a pretty even distribution of myeloablative versus not. And it seemed that there was more reduced intensity regimens than myeloablation. However, when we took all the patients into account and said, what is the rate of alloimmunization overall in the myeloablative versus reduced intensity? And this is one of the first things that reached statistical significance. Less than 1% of patients in the myeloablative group developed red cell alloantibodies, but almost, not quite, but approaching 3% of patients in the reduced intensity group did. So then we took it a little bit further, and this is one of the most interesting things to me. So if you look at myeloablative umbilical cord, myeloablative peripheral blood, and reduced intensity peripheral blood, they had all about the same number of alloantibodies developed. But when you look at reduced intensity umbilical cord blood, though it was almost approaching 4% of the, or 4.3% of the patients, and that was statistically significant. So this was a little bit confusing to us. Why would umbilical cord reduced intensity transplant and not peripheral blood lead to higher incidence of red blood cell alloimmunization? So what do you do when you don't quite know what's going on? You look into the literature. Has it been reported before? What does it mean? So this paper, which was published in BMT in 2014, discussed, and this I believe was in Spain or France, it was in Europe, but they looked at autoimmune cytopenias post-umbilical cord blood transplant. So they included autoimmune cytopenias, including hemolytic disease, autoimmune hemolytic disease, but also they included autoimmune thrombocytopenia. In this cohort, they did not have any autoimmune neutropenias to speak of. But they had a 5.4% incidence, so a little bit even higher than ours, possibly because they were including the thrombocytopenias as well. But they noticed an association between the development of these autoimmune cytopenias and an increased risk of graft versus host disease. So I wanted to go over this, what treatment options these patients got in this study, because it's kind of interesting to me how to make conclusions about this. But so they had a 5.4. They had a lot fewer patients than we did. So one patient died due to relapse disease. So these were the 3 different first-line therapies that these patients received. So 8 of 15 received prednisone or methylprednisolone alone. 2 got IVIG alone, and 4 of the 15 got rituximab as first-line therapy. When you look at the response rates, only 1 patient in this group went into complete remission, and none in the IVIG alone, but 50% of the patients who received rituximab at initial therapy went into complete remission. So 6 of the 15 required second-line therapies, including splenectomy, therapeutic plasma exchange, and then rituximab in these 2 groups. One of the most concerning things to me, though, were 67% of these patients who developed these autoimmune cytopenias post-transplant died of complications of infection, GVHD, or anemia due to hemolysis. So it appears that these cytopenias that develop in the post-transplant period are a little more resistant to treatment than non-transplant patients, and that they have a high morbidity and mortality rate. So it's a little concerning. It's something to watch out for in these patients who are getting transplanted. If they're having decreased hemoglobins or platelet counts that are unexplained otherwise, it might be something to look into. I found another paper. This is out of Blood in 2013. This, again, was in Europe. And they were looking at all types of autoimmune conditions, including hemolytic anemia. They included thrombocytopenia and immune neutropenia as well, but also the autoimmune disorders you see in solid organs, such as Hashimoto's and the thyroid. So they were seeing a increased incidence of these autoimmune conditions after a cord blood transplant. And their biggest conclusion was that patients who were getting transplanted for non-malignant conditions had the highest likelihood of developing these. But I would argue that patients who have non-malignant conditions are more likely to undergo reduced intensity regimens. But they didn't mention that in the paper, whether these patients were undergoing reduced intensity or myeloablative chemotherapy. So again, evidence to support some of our findings. So what I think of as Monty Python and now for something completely different. So we know that umbilical cord blood come from babies who have not been antigen exposed. So these are naive T cells. So the T cell repertoire in umbilical cord blood is inherently different from peripheral blood and bone marrow from people who have been exposed to things. So my thought process, I guess, is could the imbalance, I guess you can still see, I'm good. Could the imbalance between the naive T cells and the autoimmune-driven T cells through the Th17 response, and also possibly T regulatory cell differences in umbilical cord blood and peripheral blood be the reason for this? Why the reduced intensity? I think that mixed chimerism is a thought that there's some interaction with the cord blood that could lead to this. However, there are also studies showing that autologous patients have increased risk of autoimmune cytopenias, so who are receiving their own cells post-transplant. So I don't think that completely explains. In summary, I think the clinical and mechanistic effects of autoimmune disease in the post-transplant period require more investigation and research to determine possibly what some of these mechanisms are and to get these patients better therapies possibly. So in conclusion, the University of Minnesota has a very rich history in bone marrow transplant. Cord blood is a viable alternative for patients without a matched-related or unrelated donor through the NMVP. Cord blood with reduced intensity regimens are good options for certain patients, but there may be an increased predisposition to autoimmune cytopenias and possibly other autoimmune conditions as well. We are currently going back in our data. We only pulled red blood cell alloantibodies, and as a secondary finding, we found that a lot of these patients had warm autoantibodies as well. So we're going back and we're going to try to see if some patients had just warm autoantibodies that we didn't see, to get a true incidence of what this is in the post-transplant period. So there's more to come in our study. I want to say thank you to Claudia Cohn for letting me bug her all the time with my thoughts on this project. Alicia Kaplan, who is a fellow prior to me, started the efforts on this, and I'm kind of hopefully going to get it to completion. Benjamin Rio-Garce, who worked with Dr. Cohn and helped her pull all this data initially, and Dr. McKenna for his help with working on this presentation, and then all the transfusion medicine and hematopathology faculty and staff. I've had such a rich experience here at the University of Minnesota. I'm so thankful for everybody. So last but not least, I want to wish, is she in here? Amy, a very happy birthday. She has not only been instrumental in these grand rounds, but has become a friend. So happy birthday, Amy. Most important. Do we have any questions? I hope I can answer. Yeah.
That was a terrific summary. Thank you. So I just want to add a little historical color.
Yeah, awesome.
So in the late 70s, I had the good fortune of spending 2 days in John Milsey's lab in Paris.
Oh, wow.
And if you ever want to see an old lab, the hospital he worked in, the lab, and it was built in 1610. Just unbelievable. The interesting thing that Dosset did that really made him so prominent was people were trading multiparous sera around way back, trying to figure and define all these HLA antigens. So they would have international workshops every 4 years. Dosset was very clever, and being in a Catholic country, he said maybe if we had more restricted antigens present in these multiparous sera recognition, we could get better definition of this. So he went to the Archbishop of Paris and asked if he could, there was no HIPAA back then. He asked if he could get the records of all the first cousin marriages. So in order, in the Catholic Church, to get married, if you're a first cousin, you had to get permission. So he got access to those, contacted those people, got the sera from the moms, and it really was a leg up on defining a number of these antigens. So we actually had dinner at his house, and there was no lab safety. We actually had lunch in the lab with wine. It was like unbelievable, something I'll never forget.
I should have put your picture on the presentation.
No.
Yes.
So the alloantibodies, they are the former, so they're the antibodies against the new hematopoietic system, correct?
Yeah, we don't know.
No, but you should know that, right?
We also don't know we don't know the full red blood cell phenotype of the donor. We don't know the full red blood cell phenotype of the donor.
And if there's mixed chimerism.
Yes.
Now we do have sometimes red cell pellets, so some of these selectively we could try to pull those and you could phenotype them.
Because my question is, okay, so which side is making the antibodies against which side?
Mm-hmm. Yes.
Yes and yes.
Okay, so
Okay.
Thank you.
Thank you.